బ్యాక్గ్రౌండ్ అంటే మనకి ఇందులో ఉంది సార్. వీడియోది వీడియో ఉంది కదా సార్. వీడియో పక్కన బటన్ లో చూస్ ఇలా
వర్చువల్ బ్యాక్గ్రౌండ్. ఓకే ఓకే
అది సార్.
మధు
వెల్కమ్.
వర్చువల్ బ్యాక్గ్రౌండ్ లో ఎక్కడ ఉంది అది?
బ్యాక్గ్రౌండ్ అండ్ ఎఫెక్ట్స్.
అంటే మీరు డౌన్లోడ్ చేసుకోవాలి సార్ ముందు.
ఓకే, డౌన్లోడ్ చేసుకోవాలా?
మీకు పంపిస్తున్నాను, ఆగండి వాట్సాప్ లో.
అవునవును, పంపించాను. కరెక్ట్. ఈ కంప్యూటర్ నుంచి ఇలాగే చూస్తాను, ట్రై చేస్తాను. లేకపోతే నా బ్యాక్గ్రౌండ్ లోనే చేసేస్తాను.
పర్వాలేదు సార్.
ఈ రూమ్
గుడ్ ఈవినింగ్ మధు.
గుడ్ ఈవినింగ్ సార్.
గుడ్ ఈవినింగ్ శుభ్ర సార్. గుడ్ ఈవినింగ్ ప్రదీప్.
గుడ్ ఈవినింగ్.
గుడ్ ఈవినింగ్.
గుడ్ ఈవినింగ్ ఎవ్రీవన్. గోపాలకృష్ణ గారు, జేఆర్ రెడ్డి సార్, షర్మిల, లక్ష్మి గారు, మధు, వీడియో టెక్నాలజీస్, ఎవ్రీవన్.
మధు
సార్
నువ్వు 6:30కి పెడితే అలాగా, నువ్వు 7:30కి పెట్టాలి.
నెక్స్ట్ టైం నుంచి మార్చేస్తాం.
నెక్స్ట్ టైం నుంచి మార్చేసి 7:30.
అంటే యాక్చువల్ గా కొన్ని సండేసే పెట్టాం సార్, ఇది కుదరని కొన్ని ఇలా పెట్టాం.
లేదు, సండే వద్దు అసలు
సార్.
ఎనీ వర్కింగ్ డే
7:30,
8 to 10
సార్.
సాటర్డే కాకుండా ఫ్రైడే అయితే బెటర్ ఏమో చూడు మధు.
సాటర్డే కాదు, ఎనీ అదర్ డే అసలు. అంటే సాటర్డే అండ్ సండే.
మండేస్ అండ్ సాటర్డేస్ ఆర్ బిజీ డేస్ యూజువల్ గా.
నెక్స్ట్ ఏంటంటే బెస్ట్ ఎయిదర్ ట్యూస్డే ఆర్ ఫ్రైడే.
ఓకే సార్. ఓకే.
నమస్తే సార్.
గుడ్ ఈవినింగ్
సార్. నమస్తే సార్.
సార్ we have 6 more minutes.
Yeah, 6 more minutes.
Gopal Krishna garu, sir, you can start the program, sir, by describing the concept.
Okay.
And also briefly introduce the speakers also, sir.
Yes.
And from there, one by one debate, we'll take it and take the expert comments.
Sure.
I think Retina ఒకటే అజిత్ బాబు గారు కొంచెం లేట్ గా జాయిన్ అవుతానన్నారు.
Okay.
So whenever he joins, the debate will be there.
Okay.
And for the expert comments for glaucoma session, sir, I think GR Reddy garu has contacted Tanuj Dada garu and one more Pandav garu.
Sure.
They have already sent their recordings.
Okay.
So during the discussion, I'll share that recordings from my side, sir.
Sure.
So this is the approach.
So the first cornea topic, then small pupil topic, then glaucoma, retina ఎప్పుడైతే అప్పుడు అంతేనా?
Yes, sir.
Yeah. అజిత్ బాబు వచ్చి రెటినా యాడ్ చేస్తాం.
Yes, sir. ఫస్ట్ కార్నియాతో స్టార్ట్ చేసేద్దాం సార్.
ఓకే.
మధు గోపాల్ రాజు గారు జాయిన్ అవ్వలేదు
సార్. కాల్ చేస్తున్నాను సార్.
సార్ నమస్తే సార్. జేఆర్ రెడ్డి సార్, ప్రెసిడెంట్ సార్. బాగున్నాం సార్. నమస్తే సార్.
సార్ గుడ్ ఈవినింగ్.
గుడ్ ఈవినింగ్ మేడం. గుడ్ ఈవినింగ్.
సార్ ఆర్ యు ఏబుల్ టు హియర్ మీ సార్?
yes yeah. బాగుంది, వీడియో కూడా బాగుంది. గుడ్ yeah.
ఓకే.
కుదిరితే అది కూడా పెట్టండి.
సార్ అదే సార్ ట్రై చేస్తాను APOS దాన్ని పెట్టేదానికి. అది ఇప్పుడు వాట్సాప్ లో ఉండే ఇమేజ్ డౌన్లోడ్ చేసుకోలేము సార్, మెయిల్ కి పంపించేది.
వాట్సాప్ లో ఉండే ఇమేజ్ మీ సిస్టమ్ లో డౌన్లోడ్ చేసుకోండి. మీ సిస్టమ్ లో డౌన్లోడ్ చేసుకుని దాని నుంచి వర్చువల్ బ్యాక్గ్రౌండ్ లో తీసుకుంటాను అంతే.
ట్రై చేస్తాను సార్.
రామకృష్ణ గారు ఇప్పుడే కాల్ చేశాను సార్ తాడంకి, ఆయన కూడా లాగిన్ అవుతున్నారు. చంద్రమోహన్ సార్ గుడ్ ఈవినింగ్.
గుడ్ ఈవినింగ్ సార్. బ్యాక్గ్రౌండ్ పెట్టడానికి విశ్వ ప్రయత్నం చేస్తాను.
ఫస్ట్ సిస్టమ్ లో డౌన్లోడ్ చేసుకోండి సార్.
అంతా అయిపోయింది సార్.
వర్చువల్ బ్యాక్గ్రౌండ్ కానీ వర్చువల్ బ్యాక్గ్రౌండ్ కానీ సరిపోతుంది. శర్మిలా మేడం గుడ్ ఈవినింగ్. ఐఎమ్ డాక్టర్ గోపాలకృష్ణ హియర్ ఫ్రమ్ మోడర్న్ హాస్పిటల్ నెల్లూరు.
Sir, good evening, sir. We spoke over the phone, sir. I remember.
Yeah.
Good evening, sir. Good evening, sir. Reddy, sir. Good evening. All good, sir. All good, sir. Thank you, sir.
Pradeep, good
హలో
evening.
శర్మిల గారు.
Hello.
వెల్కమ్ అండి. వెల్కమ్ టు APOS.
Thank you.
Good evening,
గోపాల్
all
రాజ్
of
సార్
you.
జాయిన్ అయ్యారు.
Yeah, good evening, good evening, sir.
గుడ్ ఈవినింగ్ సార్. నమస్తే సార్.
Yeah, good evening. Allah. ఫస్ట్ ఏమైనా రీషఫుల్ చేయాలా? సుధాకర్ ట్రావెలింగ్ లో అన్నారు
సార్. ఫస్ట్ ది కార్నియా చూద్దాం సార్, లేకపోతే అప్పుడు స్మాల్ పీపుల్ స్టార్ట్ చేసేద్దాం సార్.
ఎవరో రెడీగా,
ఎందుకంటే గ్లకోమా ఇద్దరు రెడీగానే ఉన్నారు.
ఓకే,
గ్లకోమా మనకి ప్రదీప్ సార్ అని షర్మిలి మేడం రెడీగానే ఉన్నారు సార్.
2 minutes మధు ఫర్.
ఎస్ సార్, 2 minutes టు గో. ఐ థింక్ సుధాకర్ సార్ జాయిన్ అవ్వలేదు కాబట్టి గ్లకోమా స్టార్ట్ చేసేద్దాం సార్.
స్టార్ట్ చేసి
సార్ ఐ థింక్ ఆల్రెడీ స్ట్రీమింగ్ స్టార్ట్ అయిపోయింది సార్ యూట్యూబ్, ఫేస్బుక్ లో.
ప్రెసిడెంట్ గారు వెల్కమ్ అడ్రస్.
గౌతమ్, Gautam?
Yes, sir.
Yeah. Can we start?
Yes, sir. We can.
It's streaming on YouTube and Facebook?
Yes, sir. It is streaming.
Okay then. Okay. Right. Sir Gopalakrishnan, sir, please start, sir.
Yeah. Good evening, all. A warm welcome from Andhra Pradesh Ophthalmic Society. Today evening, as part of our initiative of the continuous educational programs from the APOS platform, we designed a ophthalmic debate. Most of the times, we, the practitioners or the postgrads, will have a dilemma in management of certain conditions. The debate series started today evening. We have 4 topics. One is the cornea, the glaucoma, the cataract, and the retina. Though there will not be much of a controversy will be there in the treatment options. But if you have a debate like this, we'll have the pros and cons of each procedure. So today's webinar, we are going to concentrate on the management aspects. And the webinar, we named it as a ophthalmic debates. And we have a galaxy of speakers presenting the topics, the wide range of topics. The corneal topic is the keratoconus. To debate the management as per the keratoconus, we have Dr. E.L.S. Jyoti from Nellore. She's a corneal surgeon trained at Arvind Hospital, Madurai, and she's practicing in Nellore for the last 1 decade. And she's going to speak on the collagen cross-linkage in the management of keratoconus. And to debate with her, none other than Dr. Sudhakar from Shankara, Guntur. He'll be speaking on the advantages and the role of rose K contact lens in the management of keratoconus. And we have a topic in the management of glaucoma. The glaucoma topic is the management, the minimally invasive glaucoma surgery versus the conventional trabeculectomy. We have Dr. Sharmila, faculty from Arvind Hospital, to debate in favor of MAGS, and Dr. Pradeep from Tirupati, a trained LVPA trained glaucoma consultant and practicing in Tirupati, to debate in favor of conventional trabeculectomy. And we have a diabetic retinopathy topic, and we have 2 stalwarts speaking on the management of diabetic retinopathy. One, Dr. N.C. Lakshmaya, a AIMS graduate practicing in Nandyal, and he's going to speak in favor of pan-retinal photocoagulation in the management of diabetic retinopathy. And we have Dr. K. Chandramohan, Moderator Center, Vijayawada, a alumni of Arvind, trained at Arvind Hospital under Dr. Great Dr. Nam Perumal Samgaru, and he's going to speak on the role of anti-VEGF in the treatment of diabetic retinopathy. And we have a very interesting topic, the small pupil phaco. We have two stalwarts. Both of them, they don't need any introduction. They are great. They have great fan following on the YouTubes. One is Dr. Sunil Tangaraj. He's going to speak on the role of the importance of iris hooks in the management of small pupil. And we have the stalwart, the YouTube stalwart, or I can say the megastar of YouTube, ophthalmic YouTube, Dr. Tadanki Ramakrishna, has got a lot of in favor of in the expert Dr. opinion on the current topic. And we have Dr. G.R. Reddy Garu to add his inputs on the glaucoma topic. And we are expecting Dr. Ajit Babu Bajji to have his inputs on the diabetic retinopathy management topic. And we have Dr. A. Srinivas Garu from Vijayawada Chaitanya Hospital to have the society will take the program forward. And I thank all the participants and wish all of them best, and all the postgraduates to just learn a trick or two from all this expert panel. Over to you, Madhu.
Thank you, sir. Thank you for the wonderfully designed program. I think now that we have the glaucoma panel ready, we'll start off with our guest faculty from Arvind Eye Hospital, Madurai, Dr. Sharmila ma'am. She did her post-graduation and fellowship from Arvind. She is a very senior consultant there with over 15 years of experience, and she has more than 40 publications to her credit. And she has also won several national and international awards in her field. We are very happy and glad to have you here with us, ma'am. And she'll be speaking on MIGS. Please, ma'am, go ahead with the talk.
Thank you very much. I thank the AP Society for inviting me, and thank you, Madhu, for that kind introduction. I think the host has to enable me to share my screen.
You're not able to share, ma'am?
No.
Okay. Gautam? Video, Gautam?
Yes, sir, I'm giving the access. 1 second.
Yeah, please.
Okay.
Ma'am, see, ma'am? You can try now. Yeah.
Visible. Yeah.
Are my slides visible and am I audible?
Yes, ma'am. Okay. You can go ahead.
Thank you so much. So I'm going to be talking for MIGS, and I'm going to be talking against Dr. Pradeep, who's going to be talking about trabeculectomy. So we all know that trabeculectomy is the gold standard, right from 1970s. Almost like 50 years, it has ruled the field of glaucoma. But are we still justified to still say that it is still the gold standard? No, definitely not, because trabeculectomy does have its own share of complications. So the complications seen with trabeculectomy are really vision threatening. Most importantly, we have hypotony, bleb leaks, endophthalmitis, tenon cyst, and several other vision threatening complications because of use of antimetabolites and also because of the surgery per se. Secondly, it does not work in all types of glaucoma. We might not be in a position to do it for uveitic glaucoma or neovascular glaucoma. And thirdly, we may have to follow these patients very closely to monitor the intraocular pressure and also to help in bleb survival by doing a lot of maneuvers like massage, suturolysis, or even bleb needlings. So, and also there are more to the downsides of trabeculectomy. So look at the field like this. When there is an involvement of the central fixation, we cannot proceed with the trabeculectomy because of a shutdown or macular snuff out phenomenon that might be possible, which will lose the central vision as well. Secondly, the surgical success is totally unpredictable because everybody's fibrotic response is totally different. So it is totally dependent upon the patient factors. And also we cannot repeat these procedures. Once these surgeries fail, definitely the subsequent surgery is also going to fail, and it is also not suitable to do it in a patient who has very thin sclera. So these are the downsides of trabeculectomy. And more to it, there is a major study, which is the TVT study, which has compared the tube versus trab. So these are the two major modalities of treatment for glaucoma. And even in those, they found that the trab had potentially more complications than the tube group. The total number of complications reported in the trab was 48, and that in the tube was only 36. And more to that, the failure rates were also significantly high in the trab group compared to that of the tube group. So are we still justified saying that trabeculectomy is the gold standard surgery? I think it is time to change. This is a person like Ike Ahmed who found out this minimally invasive glaucoma surgery. So these surgeries are usually an ab interno procedure with micro incision, which is minimally traumatic. It has a good efficacy, high safety profile, and more importantly, a very fast recovery. And it also delays the need for any other invasive surgery. And we can comfortably combine it with cataract surgery. And is it the new normal? Definitely yes, because even in India, there is an increased trend of MIGS, which is noted. And in USA, there has been a doubling of numbers of MIGS, which has been performed from 2013 to 2018. And today, intraocular pressure lowering efficacy with MIGS is also between 25 to 40%. And there is 50% reduction in medications, and complications are very less or almost infrequent. So this is a very important slide, which I really like, because MIGS is something which acts on the normal aqueous outflow pathways in different routes. So if there is a block which is only the trabecular outflow system, we have devices which will just target that. Or if there is something in the suprachoroidal outflow system, we have devices that target that, and subconjunctival route also we have devices. Whereas in trabeculectomy, it is all in one. Irrespective of where the pathology is, the only procedure that is done here is you shunt the aqueous from the anterior chamber to the subconjunctival space. And here are the different routes by which we have different procedures for trabecular outflow. We have stenting procedures, we have cutting procedures, dilating procedures, and we have subconjunctival route implants and suprachoroidal implants and so on. So we have plenty of options depending upon the pathology. And MIGS, when do we choose MIGS? MIGS is ideally chosen for patients with open angle glaucoma and also for mild to moderate variety of open angle glaucoma, and those patients who are on multiple medications, who are not able to tolerate the medications or because of poor compliance, and those who require a cataract surgery, and when trabeculectomy is a risk for the loss of vision. Like you can even do it in advanced stages of glaucoma, and when the conjunctiva is very unhealthy or scarred. Even in few patients now, even in primary angle closure glaucoma, it is found to be successful. Now, what are the specific advantage of MIGS over trab? So whenever we do a MIGS, it is conjunctival sparing because the incisions are pretty much like just the cataract surgery. It does not preclude future filtration surgery. But when trab fails, we cannot do a trab again. We have to go for doing a MIGS. But when MIGS fail, we can definitely do a trab again. And we also have additional procedures along with MIGS, which is called as MIGS Plus, which gives additional IOP reduction, like when we do it with a cyclodestruction. So now the big question is, my opponent, I'm sure he's changed a lot in his personal life. This is his old car, which I got it from one of my friends. So you can see where it is now, and this is his new car. So when there is a change in personal life, we also have to change in our professional life because a change is inevitable, and we definitely have to change to improve or benefit our patients. And I'm sure my opponent is always thinking about myths more than facts, because he probably is thinking that cost is a big factor. Yes, it is expensive. Who said it is not expensive? But we do have cost-effective alternatives like Bang, Suchagat, and other procedures, which is very much available in India, and it is cost-effective, and we can give for our patients. And there is also a complicated mechanism by which we do these procedures, like positioning of the patient, microscope tilt, magnification, and acquiring a gonioscopic skill, etc. But we do have certain gonio lenses which are very, very good, and they don't need any assistance, and it can be easily done with our OT settings. It is definitely time taking because every procedure will have a learning curve, and so is the MIGS. We don't master anything overnight, so it needs a lot of patience to master the technique. So these are the two studies which have compared head-on MIGS versus trab. So mix and TRAB, when they compared, they found that mix is equally effective in controlling intraocular pressure. It decreases the mean number of medications and also the patient visits with lesser complications. And the second study here is basically done after an incisional surgery. So MIGS has caused around 60 to 70% success in treating open angle glaucoma patients who had already undergone an incisional surgery. So is MIGS safe? So definitely MIGS is very, very safe compared to TRAB because it doesn't have any vision threatening complications. Only minute complications like hyphema, a small obstruction to the stent, hyphema and conjunctivitis, or persistent corneal edema are some of the complications which are noted and which are transient. And even among the mixed procedure, the procedures which involve the trabecular outflow are the very safe compared to the other procedures. Now, coming into the efficacy, efficacy wise, if you see, there is a lot of debate going on. These procedures are usually combined with cataract surgery. That is why it is showing a better response. No, I think that is also a wrong thing because there are head-on studies which have compared MIGS as a standalone procedure. For example, here they have used trabectome alone and they have also compared it with trabectome with phaco. If you see here, the efficacy is almost the same or little more in patients who have done only a standalone trabectome procedure. So similarly, iStent also. iStent as a standalone as well as iStent with phaco, the results show that IOP reduction is comparable. Likewise, KDB. KDB is another important new kid on the block which has come here. And here also combined with the phaco or standalone KDB, both have equal efficacy. So is the GAT. So we do have good outcomes with these procedures, either as a standalone or along with the cataract surgery. So it is no more considered that it works only with cataract surgery. It does work as a standalone procedure. Now, these are small 2 videos, which we generally do it in our setting because these are cost-effective devices. The one on the left is the GAT. So you just make 2 incisions, one side port and one main incision. You blunt the proline suture, 30 or 40 proline suture, and then introduce this MVR blade through the main port and make an incision in the trabecular meshwork. Once you do that, you'll open up the Schlemm's canal and slowly you feed in this proline suture into the Schlemm's canal. So around 25 to 30 passes are made, and under gonioscopic visualization, you have to see the other edge of the suture which is coming out like this, and then you pull out the proximal end. Then you create a 360-degree Schlemm's opening is created in this way. And the picture on the right is the bang procedure where a simple 25 gauge needle is used and it is bent and it is used to create a trabecular incision. So here you can see the blood which is coming out. This means that it has correctly targeted the tissue that we are aiming at. So it's a very, very simple procedure, and these are definitely very, very cost effective, which can be done without any major instrumentation or help from anybody. So what is the role of MIGS in India today? We do know that a lot of MIGS have been all used in the US or the Western countries where it is all in US dollars. But we do have cost-effective devices like what I showed now, the Proline GAT. It is probably costing only at 350 rupees, and the cost of bang is totally negligible. And we also have the KDB, which is coming up now, 30,000 rupees they are charging for one blade, and this blade is reusable for 3 patients. So it is definitely has a role, and we have to consider this. And with Aurolab, we are also coming up with an indigenous eye track catheter, which is in the making. And this will also be a future later, just like how the RD is come up. So the take-home message here is mixed surgeries are very effective at lowering intraocular pressure. MIGS is safer, minimally invasive, conjunctival sparing, faster recovery compared to the conventional trap. It has fewer complications and definitely has a scope for future incisional surgeries. It does involve a lot of skill in learning the gonioscopy. It is technically challenging, but does have a significant role in moderate and also in select cases of advanced glaucoma where trap is contraindicated. Cost-effective MIGS is an option, and it could be a game changer and possible new gold standard as well. So no more trabeculectomy as the gold standard. We might have to consider MIGS as a new gold standard. And I'm sure after listening to this, my opponent is also thinking of changing his surgery in the new year. So wish you all a happy new year, and thank you for patient hearing. Thank you.
Thank you, ma'am. So can we have Pradeep sir ready for the rebuttal? Gautam, can you please make Pradeep sir as give the screen sharing to Pradeep sir and put the spotlight on him. Yeah. Sir, you are able to share, sir?
Yeah.
Yeah. Please go ahead, sir.
Good evening, all. You have put me against a strong opponent now. So I'll try to justify myself. So how many of us have stopped doing trabeclectomy after the advent of non-penetrating glaucoma surgeries or MIGS? You can frankly judge among yourselves. And there has always been a big hullabaloo regarding the safety profile of trabeclectomy. So, and when we say complications, no surgery is immune to complications. And often the complications in trabeclectomy are also transient in nature, from which usually the patient recovers. So, incidence of sight-threatening complications, yes, even one is important for me. But what is the risk-benefit ratio when it is pertaining to disease that we are dealing with? And financial implications of disease management in our scenario, yes, whatever Madam said, that GAT or bank could be up to some extent beneficial. Well, let us see what are the pressures where they have done all these surgeries and what are the results we have seen. So could we say that MIGS is a substitute or replacement for trabeclectomy? We'll try to see as we go on. So there has always been a quest for more safer surgeries and better surgeries for trabeclectomy, so that the IOPs are better controlled and there is what we call no vision threatening complications, and then decrease in the visual field deterioration and increase in the quality of life of the person. So since 1856, you can see there have been a lot of interest in glaucoma surgeries, and day by day or year by year, they have been improving the type of surgeries and trying to make it more safer as we go on. So now in 21st century, it is there of MIGS and LIGS, but still trabeclectomy has its own place in this era. So you can see the surgeries here. These are conjunctival involving. The MIGS means the conjunctival sparing surgeries. So trabeclectomy was initially described in Keynes in 1968 and later modified by Watson and Barnett. Typically, the surgery which we are doing now is the modification, and it has evolved to become the gold standard. And the studies have again proved that always that trabeclectomy has been helpful in decreasing the field deterioration and improving the visual outcomes of the patients and avoiding patients from going blind. And when it comes to NTG patients, we need significant IOP lowering, where NTG trabeclectomy works better than any other surgery. So along with the use of anti-fibrotic agents, the pressure control has been better, but what we have seen with them is a little bit increase in the blood-related complications. So we have been modifying these surgeries with use of anti-fibrotic agents, anti-VEGFs, releasable sutures, adjustable sutures, using Bologen implant. So there has been a long list of modifications which have been done to make the surgery more and more safer. So especially in case of advanced cases, trabeclectomy will be the choice. So the technique which was described by Bluefold group by Peng Tha has always been helpful in reducing the number of complications like hypertony, leaks, and cystic plebs. So what we like to say that surgeons have always predicted the demise of trabeclectomy, but I think still it's the gold standard procedure for the patients with advanced or rapidly progressing glaucoma. And the 21st century trabeclectomy is no longer the hole in the eye where you pray it does not close, but it closes enough not to cause any complications. And it is the cheapest and invariably the simplest surgery. So when you look at these two studies which have been done long ago, that means this study has been published in 2012. So where you can see that the pressure controls are always good, but the loss of vision which has occurred in the patients has been due to what we call other causes other than glaucoma, since we know that glaucoma is a multifactorial disease. Again, this is another study which was published in 1996, where you can see the intraocular pressures were always well controlled. So we can see the non-penetrating glaucoma surgeries like sinusotomy, deep sclerectomy, viscocanalulostomy, which have always been an alternative and with a better safety profile, but you could see that they have over a period of time could not stand the test of time, have been like could not become the gold standard surgeries. So the problem with the MIGS is that it has a steep learning curve, as Madam has also described it, and it has a varying safety profile. Maybe GAT and BANG, if you take, they are cost effective, but other surgeries, they are not cost effective, and you need an expensive and sophisticated machinery, where you can see KHB, they were talking about having it for 30,000 rupees. And then you have long-term results. I don't think so we have long-term results in any of these cases. And if you look at the scenario, financial implication in our country, we cannot use those what we call sophisticated devices. So it is a subject of investment, debate, and it is increasingly researched. Although generally safer, it is a relatively new approach, and the long-term benefits for the patient and cost effectiveness are still not known. Say most of the MIGS procedures are combined with cataract extraction, as most of the studies are seen, and very few studies have just using the standalone implants. So the choice of MIGS remains still a clinical conundrum. Which glaucoma, which device? We do not really know. So for this particular glaucoma, we could use this particular device. But this trabeculectomy becomes one choice, because any surgery you can use that. And what Madam said, that we cannot use trabeculectomy in case of uveitic glaucoma, neovascular glaucoma. Yes, maybe the failure rates are more, but still it is useful in some of the patients. And we do get good results in case of uveitic glaucomas and neovascular glaucomas. And especially when you have a patient with poor visibility of angle due to corneal opacities, ocular surface disease, and extensive anterior synechiae K, where it's difficult to visualize the angle. So it's very difficult to do the MIGS procedure. And role of MIGS in angle closure, I think it's still a subject of research. So you can see the kind of complications you can occur. You can see with the MIGS, you are seeing infection could also be one of the what we call complications. So it is also not immune to endophthalmitis. You cannot just say that trabeculectomy is only surgery where you get endophthalmitis. But all the surgeries where you do intraocular procedures, they are what we call prone to have endophthalmitis. So at the same time, you can see the pressures baseline. So throughout the thing, you can see that the pressures are like in just high teens or just about 20s. There are no patients with very high pressures like 40s, 50s, where you do trabeculectomies and get a beautiful results. So this is also again the number of complications where you can see throughout the what we call spectrum, where you can see the different percentage of different complications which occur. So any surgery is not immune to what we call complications. So you can see here also there are a number of studies. The pressures are around 28. That means near 30s or higher 20s, and then less than that 20, 25. And all these pressures are like very low. You don't see a study where you have the pressures are very high, where you need an absolute control. So this is one study where you can see the vision threatening complications are less in trabeculectomy, 0.8% compared to 1% in the microshunt which has been used. There is one is called in-focus device or pressure flow, which we are using now. That is a subconjunctival device which is used. So you can see the complication rate and the pressure control is also much better in trabeculectomy compared to the what we call microshunt device. So the quality of life, if you look at with MIGS, there is no big improvement in quality of life compared to the trabeculectomy. So I still feel trabeculectomy is equally doing well with MIGS. So if you look at the different studies which have been done, you can see the studies with control group only 36% of the studies have control group, and randomized control only 18% of the studies are having randomized control. So only 24% of the studies are having any what we call control group. And when we look at the conflicts of interest, the conflict of interest is seen in 55% of the what we call studies where it is associated with the authors who are related to the companies. This is one thing from the article which I have taken, where they say that when the study is funded by the industry, the complications or results and all go in favor of the industry rather than the what we call patient benefit and all those things. So debate in the sense, the longevity and enduring popularity of trabeculectomy as an effective surgical option cannot be ignored. The huge volume of evidence in peer review, which we have been seeing for the last 50 years, and the number of different surgical modifications we have been doing to make it more safer. Now it's much more safer surgery than it was 20 or 30 years back, where we have different publications, and it is a cheap and simple operations surgery. So this is one of the quote by Dr. I.K. Ahmed himself. It is said that it is a common misinterpretation of MIGS that it needs to be compared with the gold standard of MMC trabeculectomy to show its effectiveness. It is the MIGS devices are designed to address the treatment gap that exists between the medical therapy and more aggressive traditional surgical options. Not that they will be replacing over a period of time. This is the quote by a person who is has drowned himself into these MIGS devices. So to me, the trabeculectomy is here to stay, and it will be the gold standard till a better surgery comes out. And all the newer procedures, they just work in mild to moderate glaucomas. Advanced glaucomas, we definitely need trabeculectomy. And these surgeries are not much effective in angle closure, where we have better results with trabeculectomy. Few of them are only approved for combined surgery, not standalone surgeries. And long-term results are not very gratifying, and cost factor is one of the things. And I think the quest continues for more safer, more efficacious, and economically more viable alternative. Thank you for your patience.
Thank you, sir. I think Dr. G.R. Reddy sir has requested for the expert opinion in this subject from the professors from
Madhu?
Sir. Yes, sir.
Few words, then you will share.
Yes, sir.
That.
Yes, sir.
Actually, in my opinion, it is not the question of debate. We should not call it as a debate. Actually, now we got another modality. Before TRAB, we can, because this mix can be tried along with the cataract surgery, phaco. So before and nowadays, people are start doing it, whether even though it is cost effective and it requires use better microscopes, the magnification should be very high, and with high standards of cost effective standards, only the mix can be done. And now because it started doing it by some of the ophthalmologists, there is no other option for us to get better this acquaintance and skill. We have to develop the skill to do it. And because it can be combined with the cataract surgery, we can do it, and definitely there will be a reduction of IOP. And so my advice is, if you can have a better setup and you acquire the skill, and you start doing mix before for any patient, whatever it may be, there will be definitely some lowering of the IOP, and IOP can be controlled with the only drugs. He may not go into TRAB. Suppose if the patient still the pressures are high even after MIG, then you go for TRAB, and we have another option. So one must master both the techniques, and there should not be income. It is actually pre-trabeculectomy, another such modality one can try, and we should not compare it. And the most important is one must master trabeculectomy. No escape. Because we used to do trabeculectomy with only table lamp, and with the table lamp we cannot do mix. So one must master trabeculectomy, and one must start doing the mix before now, because everyone started doing, you cannot escape. Just like what we used to discuss nearly 25 years back as SICS versus packet. Same thing. But now both we should try. Now, okay, Madhu, you can go with the.
Yes, sir. Yes, I think just to throw more light and value to this discussion, Reddiger has requested professors from All India Institute, Dr. Tanuj Dada and Pandav also to give their opinions in form of recordings. Gautam? Video, yeah, please share Tanuj Dada sir's audio. Yeah. Can you play the audio, please? The audio is not audible.
Not audible. Yeah.
Okay, maybe meanwhile I'll share Pandav sir's thing. You be ready with the audio for the next sharing. Yeah, Gautam, share the audio.
If a patient has moderate to advanced glaucoma, the target IOP required is less than 15 millimeters of mercury, and for this the only surgical option is trabeculectomy and not minimally invasive glaucoma surgery. The new implants such as the Zen implant and the pressure flow MIGS techniques have much poor outcomes as compared to trabeculectomy and are much more expensive. In patients of ocular hypertension and early glaucoma, MIGS can be combined with cataract surgery, but the implants which are currently used, such as the eye stent, have very poor efficacy and a very high cost, and I would not recommend them for any glaucoma patient. The other techniques which are commonly used, such as the GAT or the bank technique, can be used, but you should never operate on more than 180 degree of the trabecular meshwork, because the IOP lowering outcome has been shown to be similar if you operate 180 degree or 360 degree. So GAT is okay, but never 360 degree. And the other option is ab interno goniectomy, 30 to 60 degree of the angle circumference. The Kahoot dual blade is also available, but I feel the same surgical result can be achieved by just using a 26 gauge needle. So MIGS remains an option for ocular hypertension and early glaucoma, and you should use low cost MIGS techniques such as BANG or GAT. As far as moderate to advanced glaucoma is concerned, trabeculectomy remains the gold standard surgery of choice. Currently, there is a disparity between the existing quality of evidence on the effectiveness of MIGS and its adoption by various clinicians. So the current usage of MIGS is not strongly evidence-based or standardized, and the allocation of patients to particular type of device proceeds without any objective criteria. So mostly a lot of surgeons are adopting MIGS due to peer pressure and because of high economic gains, but the IOP lowering efficacy is very low. In general, I don't think it is a surgery which has a long-term IOP control and is a good option for our country. Thank you.
Yeah. Gautam, can you stop sharing? Yeah, just we have one more video from Dr. Pandav. Is the audio audible?
No, sir.
Audio not audible. Yeah.
Audio, that you go back again.
Sir, you stop sharing and again start it. While starting, you should do optimize for video. You should select the checkbox.
Okay, okay. So I think there is some problem with the audio. Okay, if we have time, we'll play this in the last.
And yeah, yes.
Yeah, so we'll go to the next debate. I think we have Dr. Sudhakar sir, who has joined us for the first cornea debate. So yeah, please go ahead, sir. Share your screen.
Am I audible?
Yes, sir, you're audible.
Okay, I thought the cross-linking would speak first, but no problem, I'll speak.
Yeah, you can, we are in a different place, so you can start your debate.
Sure,
Lalita
okay.
ma'am. Yeah.
Is it okay now? Is my screen visible?
Yes, sir.
No,
No, your screen is not visible.
Not yet, okay.
Gautam?
1 second. Now is it visible?
Yeah, yeah. Yes, sir. Make it full screen, slideshow.
Yeah, I'll do that.
Yes, sir, visible, yeah.
Visible, okay. Thank you for
Right,
the
good.
opportunity. This is the great APOS debate, December 24th. And I'm defending the rigid contact lens use for keratoconus. I'm Sudhakar, Chief Medical Officer in Guntur, Shankara. Okay, so this is my standard disclosure. There is no financial interest. And the additional disclaimer is the point of a debate is to highlight the benefits of one treatment while highlighting the drawbacks of the other. In reality, every treatment has its unique role in the comprehensive management of our patients. What keratoconic patient to us with? He comes with unsatisfactory vision, even with frequent change of glasses, eye rubbing, and really pain due to eye drops. And what are the contact lenses available for us to treat keratoconus in India? I'm not talking about Moorfields or some hi-fi place, but all these lenses are available to us, and all ophthalmologists, especially cornea specialists, should be able to dispense these because this is the best way or the best treatment for our keratoconic patients. We have soft toric lenses, which can correct cylinder up to 2.25 cell. We have RGP lenses. We have Rose-K, the Rose-K 2, and we also have corneoscleral and mini-scleral lenses, which are literally new kids on the block and which have vastly increased the usage of contact lens in keratoconus patients, predominantly because of their very comfortable wearing patterns and of course the fantastic vision that they give. What are the myths of rigid contact lenses? Why are people not using rigid contact lenses? One, the first myth is that they are uncomfortable, which is only partially true. Traditional RGP lenses can be uncomfortable in the beginning, but after adaptation, most patients find the benefits of clear visions far outweigh the mild discomfort that they have. Corneoscleral lenses and mini-scleral lenses are extremely comfortable as they eliminate the lid-lens interactions and also have minimal lens movements. And what is the other myth of the rigid contact lens? And that lenses are difficult to use and maintain. But the truth is, once proper training is given, it takes less than 5 minutes of time. So you have to decide whether 5 minutes of time or 5 lines of visual acuity is better or not. So who are we? We are ophthalmologists, and our job is to primarily improve the vision of our patients. So how do we judge up these two treatments that we have? So let us get back to our keratoconic patient. He has poor vision with glasses. Do contact lenses correct it? Of course. And all the S's are the additional strong force that we say with confidence that our lenses improve the vision. Does cross-linking improve anybody's vision? No, it only stabilizes. And 1/3 of patients actually scar and leave, and they have a drop of visual acuity, loss of best corrected visual acuity by 1 or 2 lines. The frequent change of glasses. Does contact lenses eliminate or decrease this? Again, an emphatic yes. We should realize that keratoconus frequent change of glasses is not due to progression. Part of it is due to progression, but actually it is due to the irregular astigmatism. Now, irregular astigmatism, the patient will look at one angle, gets refracted by the optometrist or the refractionist or the medical doctor for a particular axis. And then he goes back home, and then he realized that in another angle, the glasses are not very clear. So he goes back to another doctor, because since the first guy did not give the correct glasses. So he goes back to another glass, and another slight change in head position or head neck position will give you a different axis of refraction. And then he will get another pair of glasses. So this is whereas when you eliminate that, the causing factor for frequent change of glasses is irregular astigmatism, and contact lenses eliminate or decrease the irregular astigmatism. And that is why they decrease the change of frequency of glasses. Do cross-linking really affect the change in glasses? Maybe a little, but not too much. And the primary cause today, it is genetic is there, but the primary cause that we see a huge gush of keratogenic patients is really because of eye rubbing. Now, contact lenses, do they decrease eye rubbing? Lenses like the Bros lens or the Boston lens, by changing the artificial with a saline, by changing the milieu of the conjunctival sac and the saline inside, actually partially benefit in terms of decreasing the inflammation in the output. But cross-linking does not do anything like that. So eye rubbing will be decreased, can be decreased by contact lenses, and also be helpful. And is it useful in advanced keratoconus? So many times we see people with less than 400 microns of corneal thickness come to us. You can't cross-link them. People will say there are advanced or thin cornea protocols. But actually, what is thin cornea protocol? It is decreasing the amount of radiation, UVA radiation, so that there is no endothelial damage. So by increasing safety measure, you're actually decreasing the effectiveness of cross-linking itself. So nobody talks about decreasing effect. They only say we can also cross-link because it's a procedure that you can charge. But actually, it is suboptimal cross-linking, the advanced or thin cornea protocols. And so therefore, whereas in your contact lens can be even given to 100 thickness micron cornea also, and they will still improve the vision. In fact, there is enough literature that says that advanced graft is worse than a rigid contact lens, a miniscleral or a corneoscleral lens. It gives you better vision, and it decreases the effects of or the possibilities of rejection, etc. And the proof of the pudding is in the eating. So this is our own first year results when we started using miniscleral lenses many years ago. And if you see the table that was presented there, and you see uncorrected visual acuity in the left column is anywhere between 1/60 and the maximum is 6/60 in this set of patients. Whereas in the third column, which says miniscleral corrected acuity, all of them are 6/12, 6/9, or 6/6. And this is without glare. It's not in one particular angle that the glasses are acting and you are able to manage to read that acuity. No, this is all field and without astigmatism, without distortion, without glare, clear visual acuity that you have. So if you see, there are 8 to 10 lines of gain that the patient has with a scleral lens compared to anything that nothing can match this, not even a DAL can match this. And therefore, with all due respect, and so ladies and gentlemen and of the jury, I rest my case that corneoscleral lenses or rigid lenses are far better than any other therapeutic modality we have in keratoconus. Thank you.
Thank you, sir. You can stop sharing your screen now. Lalita ma'am, are you ready with your debate?
Yeah.
Yes, Madhu.
Yeah. Gautam, can you please put the spotlight on Lalita ma'am and she'll start sharing the screen. Yes, ma'am, you can go ahead. Your slides are visible.
Okay, fine. Thank you. Good evening, everyone. So as I have discussed with Dr. Sudhakar sir, I would like to debate with him on few concepts. Like, of course, Rosca lens is useful as a visual rehabilitative measure for the keratoconus patients. But how do you give Rosca lens to your patient? Do you give it before cross-linking? No. Cross-linking has to be done as a preliminary measure and then only go ahead with the other visual rehabilitative measure, because that is a procedure which will arrest the progression of the disease and stabilize the cone. That's the only proven and established procedure to halt the progression of the keratoconus and also gives the stability of the keratoconus. So as we all know, the basic principle of cross-linking is because of use of UVA radiation in the presence of this riboflavin as a photosensitizer, that will give the free oxygen radicals that will help in the increasing the covalent bonds between the collagen fibrils. So that will increase the biomechanical strength of the cornea, and thus it will stabilize the cone. So only after stabilization of the cone only we can give the further rehabilitation of the further rehabilitative measures, whether it could be rose lens or PRK or many scleral lens or whatever it is. So if you give a rose lens in the initial phase and if you don't cross-link the patient, after 6 months he again comes with the increase in the disease and increase in the cylinder power. Again, you need to change your rose lens. So the cost is again, it's going to up the burden. And this is a simple video showing the keratoconus procedure, removing the central epithelium using the swab soaked in 20% ethyl alcohol for 30 seconds. And the loose epithelium is removed with the Merocil sponge. We place a limbal protection ring and start soaking the cornea for at least 10 minutes with riboflavin drops. So after the cross-linking for about 10 minutes, then remove the limbal protection ring and saline wash is being done and the bandage contact lens can be placed. This is a simple procedure that can be done. And we have different protocols of this, Dresden's protocol, the standard one and the accelerated one, which we can titrate according to the severity of the cone. And with simple post-op care of antibiotics and steroid eye drops. We start steroid eye drops after 1 week after the epithelium is healed completely, and then the lubricating eye drops. So I'd like to support the usefulness of cross-linking as a basic maneuver before rehabilitating the patient visually for keratoconus patient. So here's a 13-year-old boy with recurrent episodes of redness, itching, and blurred vision from almost 3 to 6 months. So on examination, his uncorrected visual acuity was 6/18 and with pinhole 6/12. And the refraction was minus 2.5 sphere and 4 cylinder. And despite that, it was improving only to 6/12 parts. And same way in the left eye, he was accepting minus 5 cylinder, but the best corrector was only 6/12. And being this the pediatric age group, the patient, 13 years, neither he is in a condition to handle the contact lens, nor to maintain the hygiene of the contact lens. And because of his allergic condition, the VKC, and we cannot give rose lens to this patient. So I just gave a trial of rose lens just to rule out the amblyopia and to know his visual potential. So as it was improving to 6/9, I just went ahead with the collagen cross-linking in both eyes. So here we can see the report of the right eye and the left eye. We can see the best corrected in the pre-op, it was 5 cylinder, 6/12 in the left hand, improving to 6/6 with minus 2 cylinder itself. There is a flattening and the astigmatism has been reduced. You can see the mean K values being reduced from minus 48.4 to 46.9 diopters. Similarly, one more 23 years old presented to us for a refractive surgery routine checkup. So she was actually planning for marriage in a period of 2 to 3 months, next 2 to 3 months. On her examination, the visual acuity was minus 1.5, improving to 6/6, and in the left eye 2 sphere and 1.75 cylinder at 130 degrees. So here are the pre-op reports. So we can see like this is the right eye and this is the left eye. But the right eye map was normal almost, very minimal against the rule astigmatism, and the thickness was also normal. And the posterior elevation was also, it was not showing much float. But the left eye was showing the typical inferior cone and the posterior tongue-shaped eye line. So right eye I wanted to observe, but left eye went ahead with the cross-linking along with the topoguided PRK. I have ablative for minus 1 diopter and 1.75 diopter cylinder. So post-operative, the vision has improved almost to like 6-9 parts in the left eye with 0.5 diopter cylinder. It's like minimal. It has improved to 6.6. So we can see the astigmatism has dropped from 2.2 to 1.9 diopters, and same way the mean K value has also increased about 1.1 diopter. This is the third case, the female, both eyes she was having minus 3.25 cylinder right eye and improving to -4. So this was like her refraction was kept on increasing every 4 months, and now it is 6.9. From -1 she has started, and now it is -4. And the same way in the left eye also. Similarly, I have advanced C3R with topo-guided PRK. We can see the results. The pre of the uncorrected visual acuity -4 diopters at 30 degrees, because the thickness was almost around 520 microns. So I tried to ablate the 3.5 cylinders, almost like 80% cylinder I wanted to remove. So in this procedure, the cone is stabilized, and we can the patient's uncorrected visual acuity has improved to 6-9 parts. This is for the right eye. And left eye also, it was -2 cylinder, and the thickness was supporting for me to ablate the total cylinder. So I have removed almost, along with the C3R, I have done the PRK -2 cylinder. It's almost like 0.5 cylinder. Astigmatism has grossly dropped, and there is no need for contact lens also. So collagen cross-linking for keratoconus, it's a proven and it's established treatment, and it improves the uncorrected visual acuity, the best corrected visual acuity, and meanwhile it shapes the cone. The mean K also decreases. Of course, it's not more alone. Only if CXL is used alone, it doesn't improve the visual acuity, but it stabilizes the cone so that we can use the further measures to improve the vision. Like the functional vision is not improved much with CXL alone, but we can have the other options like PRK or Intax, or we can even go for toric ICL. That's what all these studies have proved. So I would like to say that as in the first case I have shown, that's a boy. Pediatric, so he always needs the support of parents and parents' time. And because he's having allergic condition, he can't handle the lens. So rose scale lens is not useful. And same way the expenses when you account for C3R is like single time procedure. You need not repeat it, or you need not change it. Rose scale lens, you need to keep on changing it every 1 year, 1.5 years. Depends on the durability and the maintenance of the patient, and it's more or a costly procedure, time taking to learn. Of course, as sir has said, once the patient learns, it's easy to manage and the quality of vision is more. But without doing C3R, you give rose scale lens or scleral lens, whatever it is, like after 6 months, again the cone progresses, and again you need to change the lens, and again you need to buy a newer lens. So it's going to be an expensive procedure for the patient. And when we have many more options available, not just rose scale lens or not any PRK, like along with C3R. So I would like to compare, like C3R has to be done for the patient initially, and then only go for the rehabilitative procedure. So, and this is the only available procedure till date to arrest the progression of the disease. So if you don't arrest the progression, the cone keeps on increasing, and you need to keep on changing your lens, whether it's rose scale, mini scleral or scleral, whatever it is. And moreover, it can't be used in the pediatric and allergic patients. So I would like to compare the contact lens procedure with like Ganesha Puja. Like, so whatever you do, whether any marriage or any inauguration or any function, anything you have to do, you do Ganesha Puja and then only do the other puja. It would be successful. The same way, C3R is like the initial procedure where we need to stabilize the cone. Then only you do whatever you want, whether it could be rose scale lens or PRK or Intax or ICL. And moreover, I feel like I would have done almost around 400 to 500 procedures of C3R. Like I have seen, like initial days of my career when I was doing more keratoplastics for the keratoconus. But now with the cross-linking procedure and with many other options, we are able to, and with the newer technology, we are able to diagnose it also in the early phase. And we can avoid the corneal transplantation rates, which is more important in India, where we have the tissue deficit and the cost of the procedure and post-operative maintenance also. Thank you.
Thank you, ma'am. Thank you so much. I think now I request Gopal Raju sir, the subject expert, to give. You can stop sharing your screen, ma'am. Yeah. Gopal Raju sir.
No rebuttal?
Sir, yeah, we'll give time.
You do, sir. You can give delivered, sir.
No, now or after Gopal Raju, sir?
After Gopal Raju.
I think case should be adjourned for the
Actually, rebuttal
next
should be
hearing.
immediate. Rebuttal should be immediate. After
Yes, sir.
that, the expert opinion.
Expert committee. That's sir. You're right, sir. Ajit sir, you're right.
You can go, sir.
Sudhakar, go ahead. Yeah.
Okay, so my rebuttal is my learned opponent thinks that cross-linking is the only way to arrest, but there are two essential things. One is genetics, one is rub. There is an old dictum in cornea that no rub, no cone. So therefore, you treat allergy, the cone will arrest itself. You will not cross-link till there is progression, right? Progression is diagnosed at the end of 1 year. Okay, all your criteria for progression are 1 year diametric sequential follow-ups, except for pediatric cases. So therefore, when you have a patient with keratoconus, you will say, I have to cross-link first. And when there is no progression, you will not cross-link. So you will wait for 1 full year for visual rehabilitation. You are delaying it, unnecessarily creating hassles for the patient. He can't drive properly. If he lands up with an accident, what will you do? And nicely, you are masalifying your results with addition of PRK. You are supposed to speak on cross-linking. You leave that. Don't add additional masala and garam masala and anything else.
Yes,
you are supposed to talk only about cross-linking.
Even rose lens is like masala. C3R is the main.
Exactly. So therefore, you are jacking up your results with that. So you first treat the allergy properly, and the cone will automatically stop. There are so many patients for years we have managed them with stable cones. I have cones even at pediatric follow-up. When I control my allergy, I have 5 to 6 years of no cone progression. So therefore, let us treat allergy. Let us be ophthalmologists, treat and symptomatically cure the allergy, and therefore the cone will not automatically progress. Let us not wait for years for the cone to stop, and then you take one more. What if you stop? After 3 years also, you will not be able to.
Sir, I would agree. Definitely, the first I give to my allergy patient, especially VKC with KC, is do you have the rubbing habit? And that's the first advice I give, to stop rubbing. But rubbing doesn't serve you. I think I have seen many VKC with KC patients till 18 years. How much ever medication you give also, like it's controlled in some patients, but even with medications, it doesn't get controlled. So I wait for the face to be quiescent for the allergy. Then only I cross-link the patient, not at the first sitting. And for elderly patients, I do wait for the progression, but especially for the pediatric patients in the age of 40.
So you wait for control of allergy, you wait for control of the cross-linking, and you wait for 3 months for the haze to stabilize. 2 years, 3 years later.
I don't wait for 2 years. I wait for the allergy to be controlled to cross-link the cornea.
Yeah. I think the wise old judge Gopal Raju sir needs to come in now.
Yes, now he's got to come in now.
Yeah. I think both have the points to make. There are different cases where the rose and the options are available, and then some of the cases where after the class linking that can be done, or some of the cases where class linking can be done by initial management, like Sudhakar said. I think both congratulate you for presenting and bringing out all the points relevant to the keratoconus and the use of contact lens, and then the collagen cross-linking.
Yeah, I think excellent points.
Where I protest.
Yes,
so it is never a draw. It is never a draw. One has to win the case.
This case is adjourned.
Actually, both the procedures are complementary to each other.
No, actually,
ophthalmology has won.
I agree with Dr. Madhu that it is actually a synergistic effect. I don't.
Synergistic, yeah.
No, actually,
because
that
both
is a
of them have
synergistic
really
measure.
got down the number of DALs we do for keratoconus.
Yes.
And one point I just wanted to, regarding Sudhakar sir's presentation, sir was mentioning about scarring. I think it's more of a haze, sir. Scarring we don't see much often.
Yeah.
Haze, and
but there is a loss of BCVA. There is a lot. That's what I wanted to say.
That's a transient.
Some patients do experience loss of best corrected visual acuity.
Correct, sir. Yeah.
Sir,
Thank you
actually,
so much, both of you.
Sir, when I contacted at Sudhakar about this topic, he said it's a complimentary, there's no debate in this. But
Correct.
actually, he made a very good debate out of it. Yeah. Congrats, Sudhakar.
Yeah. Excellent. Both of you, great work. Thank you.
Very good.
Now we'll
Thank
go
you.
to the retina session. I think we have the subject expert, Dr. Ajit Babu sir has joined us now. Sir, Chandramohan sir, would you like to go first or Lakshmaya sir?
Both of you are unshare. Jyoti, you have to unshare. Yeah.
Yes, sir. Yes.
Lakshmaya sir will present first.
Yeah. Lakshmaya sir, please go ahead with your.
Madhu, good evening. Thank you for calling me taking me into this debate. I've shared my presentation with Gautam. Gautam, please play the presentation.
Jyoti, you have to unshare.
Yes, sir. Sir, how to do that, sir?
It will be on the top of it.
Gautam?
Yeah,
Gautam.
ma'am has to unshare first. Yeah.
Yes.
Yeah.
Yes. Yeah.
Yes, sir. Now it is visible, sir. Please go ahead.
The spotlight should be on the Lakshmi sir. Yeah.
Diabetic retinopathy is one of the leading causes of preventable blindness. The advent of anti-VEGF has revolutionized the treatment of many retinal disorders, including diabetic retinopathy. However, pan-retinal photocoagulation remains the gold standard of initial therapy for proliferative diabetic retinopathy and its neovascular complications. Today, we will discuss the role of PRP and anti-VEGF in treatment of PDR. I will be discussing PRP and anti-VEGF will be dealt by my dear friend Dr. Chandramohan. Before going into treatment, let us see the pathogenesis of diabetic retinopathy. As we all know, diabetic retinopathy is a macroangiopathy. There are two types of pathology. One is the leakage of capillaries leading to retinal edema, the other being the closure of retinal capillaries leading to retinal ischemia. The hypoxic inner retinal layer produces a variety of growth factors like vascular endothelial growth factor. These growth factors stimulate the formation of new abnormal capillaries, leading to neovascularization. Now coming to the treatment of PRP, how does it work? Photocoagulation destroys the outer photoreceptors and retinal pigment epithelium. There is improved oxygen supply to areas of inner retina that had become oxygen deprived because of poor perfusion of inner retinal vessels. This is because the choriocapillaries is now physically closer to the inner retina as the metabolically active rods and cones are no longer present to absorb oxygen from the choriocapillaries in the area of buns. As a result, there is a decreasing number of viable hypoxic cells producing VEGF and other growth factors. So the new vessels generally regress and may disappear altogether. PRP is the gold standard treatment and has been tested for almost 4 to 5 decades. There is strong evidence for DRS and strong evidence for PRP through multiple studies like DRS and ETDRS. Coming to the studies, diabetic retinopathy study. This was done to determine the photocoagulation is helpful in preventing severe visual loss in proliferative diabetic retinopathy and to determine whether there is any difference in efficacy and safety regarding argon versus xenon photocoagulation for proliferative diabetic retinopathy. Around 2,000 patients were enrolled for this randomized control trial. The conclusion of diabetic retinopathy study showed that laser photocoagulation reduces the risk of severe vision loss in high-risk PDR group by more than 50%. This study also identified a stage of retinopathy, high-risk PDR, where the benefits of photocoagulation outweighed the risk. The 5-year rate of severe visual loss reduced from 50% in untreated eyes to 20% in treated eyes. The high-risk PDR is NVD of more than 1/4 optic disc, NVE of more than 1 disc diameter, any NVE or NVD associated with pre-retinal hemorrhage or vitreous hemorrhage. Early treatment diabetic retinopathy study. This is rated as one of the best randomized control trial in the recent days. Around 4,000 patients were enrolled in this study. This was done mainly to compare the early photocoagulation and deferred photocoagulation in patients with mild to severe NPDR, and also to evaluate the effect of photocoagulation for diabetic macular edema, to determine the possible effects of aspirin on diabetic retinopathy. The recommendations of ETDRS are: PRP should be promptly done in high-risk PDR. It is not indicated in mild to moderate NPDR. And PRP can be done in severe NPDR and early PDR if you think the patient will not be followed properly, a poor compliance. And type 2 diabetics is preferable to do early PRP compared to type 1 diabetes, and associated risk factors like pregnancy, renal failure, poor glycemic control, and extreme illness. Coming to effect of anti-VEGF, the Proteus study compared the efficacy of ranibizumab plus PRP versus PRP alone. This study showed that there was better visual outcome and control of neovascularization was better in combination therapy when compared to PRP alone. The Panorama study showed that anti-VEGF injections can regress diabetic retinopathy severity and also has a lower likelihood of macular edema with repeated anti-VEGF injections. However, those patients who had evidence regressed diabetic retinopathy after anti-VEGF injections, if they discontinued the treatment, there was more rapid worsening in these patients. So, compliance is very important for anti-VEGF injections, and there should be a continuous monitoring. The Permeate study also showed that although there was improvement in leakage with regular injections, the underlying ischemic index did not improve and in fact worsened after 12 months of regular injections. This ischemia would manifest as a peripheral non-perfusion, and this continues unabated in the setting of anti-VEGF monotherapy. This is a picture of full scatter PRP, usually done in 2 to 3 sittings, 600 to 800 spots in each sitting. Usually the size of the burn is 500 microns and placed at one burn width apart. This is mild scatter. Single sitting is sufficient. Around 6 to 800 spots are given with 2 burn width apart. Complications of PRP include mainly diminished contrast sensitivity and some loss of visual field. There can be some inadvertent foveal or optic disc damage due to damage to ocular structures. These are usually due to inadvertent procedure. These can be avoided by proper care while doing PRP. There is a study which showed that although there is a visual field loss, none of this did not affect their driving ability, and there was no increased risk of accidents in these patients who had already had PRP. So rest of all the complications can either be avoided by doing the procedure carefully, or most of them are transient and self-limited. So points against anti-VEGF. Anti-VEGF does not address the basic pathology ischemia, so needs repeated injections. This is an intraocular procedure carrying the risk of infection and endophthalmitis with each injection. There is no endpoint for treatment. Cost of treatment is high as the patient needs repeated injections. Risk of systemic complications and the high amount of compliance is needed. And if lost follow-up, they may land up in severe complications like neovascular glaucoma and advanced diabetic retinopathy. Strong points in support of PRP include: this treatment is being tested by many studies and almost has been continued for 4 to 5 decades. The treatment is finite, unlike anti-VEGF. This is not an external procedure, so no risk of endophthalmitis, no systemic side effects. More importantly, economically viable against infinite number of anti-VEGF injections. Thank you.
Thank you, sir. I think Chandramohan sir, are you ready, sir, with your?
Yeah. I'll share my slides.
ಅದು స్పాట్లైట్ చేంజ్ చేయమని చెప్తావు అతనికి, గౌతమ్కి.
Are my slides?
Yes, sir. Yes.
మధు స్పాట్లైట్ చంద్రబాబు మీద పెట్టమని చెప్పు.
Yes, sir. Yes, sir.
He is not leading. Yeah.
Gautam, can you put the spotlight on Chandra Mohan, sir? Sir, your slides are visible, sir. Go ahead.
Shall I start my presentation?
Yes, sir. Voice koncham weak ga undi, sir.
ఇప్పుడు audible గా ఉందా?
It better, sir. Better, yeah.
Go for full screen.
Slide show ki వెళ్ళిపోండి.
Yeah, slide show, sir. Yeah, that's right.
Spot లోనే ఉంది సార్, ఫుల్ స్క్రీన్ లోనే ఉంది సార్.
మాకు ఇక్కడ ఇంకా వ్యూ రావట్లేదు సార్, ఫుల్ వ్యూ రావట్లా.
ఫుల్ స్క్రీన్ లోనే ఉంది ఇక్కడ.
పవర్ పాయింట్ లో ఫుల్ స్క్రీన్ చేయండి.
స్లైడ్ షో
ఫుల్ స్క్రీన్ లో ఉంది సార్.
స్లైడ్ షో చేసారా? F5 కొట్టండి, F5 స్లైడ్ షో.
కిందకి వచ్చి ప్లే ఆప్షన్ కొట్టండి సార్, కింద లాస్ట్.
ఇప్పుడు ఉందా సార్? ఇప్పుడు వచ్చింది సార్ ఫుల్ స్లైడ్?
లేదు లేదు,
మాకు సిస్టమ్ లో ఫుల్ స్లైడే కనబడుతుంది సార్.
Go ahead, sir.
స్టాప్ షేర్ చేసి మళ్ళీ చేయండి సార్, న్యూ షేర్.
Unshare and reshare.
Yeah.
Ajit Babu garu, good evening.
You can select the resume slide show, sir.
Okay, is it full screen now?
Yeah, yes. Yes.
Okay.
You are, sir. You are on screen. Yeah, go ahead, sir.
Yeah. Please go ahead.
Thank you. Thank you. Thank you, ASF AP for giving me this opportunity to
Speak a little loud, sir.
కొంచెం కోల్డ్ గా ఉంది, but I'll try to speak loudly.
Your volume is low.
My topic for today's debate is anti-VEGF for proliferative diabetic retinopathy. So I knew after my senior colleague Lakshmi sir's talk, I will get this doubt whether there is an alternative treatment that is needed for PDR at all. Sir has told that PRP is the best treatment. Then I started my debate with this question: is there an alternative need for the treatment of PDR? So PRP, whatever said and done, is a destructive procedure where we ablate and destroy the less important retina, that is mid-peripheral retina, to preserve the central vision. So it's definitely associated with some complications like decreased visual acuity than the presenting visual acuity in many cases, peripheral field loss, decreased night vision, decreased contrast sensitivity. So definitely the study itself, Sir itself had told that the aim of the study itself was to prevent severe vision loss, that is, prevent the people from becoming 5/60. So we are not talking about improvement of vision, we are talking about making people not to become blind by doing PRP. So PRP is not a very effective treatment in the case of PDR with central involved macular edema. That is, in ETDR study itself, they have shown that 35% of the cases of PDR presented with central involved macular edema where they didn't offer any treatment. They did offer focal laser photocoagulation for CSME, but not with central involved macular edema. That is 35% of these cases. So 35% of these cases, they are treated only for PDR, not treated with for associated complications. So definitely there is a need for further treatment, further next treatment. And we all know that VEGF is an important inflammatory mediator, and it is a key factor for this microvascular leakages that occur and resulting in edema or microvascular ischemia causing new vessel formation. VEGF is the key factor. And several studies have reported increased VEGF levels. If you see any of these studies, the level of VEGF in anterior chamber in non-diabetics is very, very less. But as the stage of diabetic retinopathy increases, this is in non-diabetics, diabetics, and if mild to severe NPDR. So with the increasing stage of diabetic retinopathy, the VEGF levels in the aqueous keep increasing. So VEGF is an important inflammatory mediator. VEGF-A is the predominant inflammatory mediator because its levels are increased in vitreous in eyes with proliferative diabetic retinopathy, and retinal VEGF levels are elevated in experimental diabetics, and DR patients have higher aqueous levels of VEGF-A. So now we have a pathway which, if we can block it properly, can stop some of these effects of proliferative diabetic retinopathy as well as macular edema. So in this regard, I would like to present one important study protocol S done by DRC, Diabetic Retinopathy Clinical Research Study Group, where they had the primary question from PRP versus ranibizumab for different PDR. And they had 304 patients, 191 randomized for ranibizumab group and 203 for PRP group. Though the numbers are less, but it's also a strictly done randomized controlled trial. So the primary question was, is the visual acuity of ranibizumab for PDR not worse than the treatment with PRP? So we are comparing it with PRP. So our treatment, is it comparable to PRP? It is not worse than PRP. Non-inferiority means 5 letters again. They have also answered the secondary questions like vision throughout the follow-up area. Throughout the follow-up, whether the vision with this treatment is better with PRP or worse than PRP, whatever it is. What is the effect of this treatment on peripheral vision? What is the effect on macular edema? And what is the incidence of vitrectomy? These are the secondary questions that have been asked in this study. So in ranibizumab group, if you see, monthly injections, 4 weekly, monthly injections were given for first 6 months. Unless new vessel has regressed at the end of 4 months or 5 months, then they stop the injection. And again, after 6 months, if the new vessel increased compared to any previous 3 consecutive visits, injection is given. Withhold the injection if new vessel is stable over the 3 consecutive 3 visits. So after injection withheld, resume injection if new vessel worsens. So first 6 injections every month, monthly, and then after that injection whenever there is a worsening of new vessel formation. They had PRP group also. PRP group, same like what they did in ETRS, 1 to 3 sittings, 8 weeks apart, 1200, 800 months, all are same. But one difference is ranibizumab required for eyes with center involved diabetic macular edema baseline. So they have allowed use of ranibizumab for center involved macular edema patients with PDR. If the size of amount of new vessel increased following initial PRP, then additional PRP was given. So in the PRP group, not only they treated with PRP, they also added ranibizumab if there is a center involved macular edema. So if you see the number of injections in ranibizumab, everybody will be interested in this. How many number of injections have to be given? So the mean number of injections are 9 injections in the first 1 year. There are 2 subgroups: eyes with baseline DME, eyes without baseline DME. So in ranibizumab group, when there is no eyes without with the DME, 9 injections were needed, and 14 injections approximately were needed for 2 years up to 2 years. So 9 injections in 1 year, 14 injections. So second year there was less number of injections needed. So eyes without DME, 7 injections and 10 injections. So the number of injections in patients without DME is definitely less when compared to patients with DME. So in PRP group, ranibizumab treatment for DME. This is a very important slide I would like to show. ETDRS had shown that 35% of patients had center involved macular edema PDR group, which they didn't treat. But in this study is also confirmatory that there is at baseline 35% of high risk proliferative diabetic retinopathy patients have center involved macular edema, which will not be addressed if you do only pan-treatment photocoagulation. So you will address only PDR component of proliferative diabetic component only with PRP, but we will not be addressing this macular edema in 35% of patients. I would like to bring to your notice also 18% of patients with high risk PDR who did not have macular edema at presentation developed macular edema in the meantime. So in PDR patients, when you are following them up, if you are treated only with PRP, 18% of them are developing macular edema, and still you would need some other treatment other than PRP for this treatment. So 35% of the initial patients need an additional treatment, and 18% of follow-up patients will need additional treatment. So you cannot treat these center involved macular edema patients only with PRP alone, and outcomes are not good. The number of ranibizumab injections per DME. So this is a group where PRP is done. Eyes with baseline diabetic macular edema, eyes without baseline diabetic edema. So in PDR patients without macular edema, no injections were given. Only PRP was done. In patients with center involved macular edema and PDR, the number of injections are 5 and 9. So I want to bring to your notice also. See, there is an additional benefit of adding anti-VEGF and PRP. See, if you don't add in eyes with the baseline DME, 9 injections in 1 year, total 14 injections at the end of 2 years. But if PRP is added, 6 injections in 1 year, only 9 injections in total in 2 years. So definitely the number of injections to be given to macular edema also decreases if you add PRP. So there is a synergistic effect. Even in patients without DME, there were a few patients which needed second year because the edema appears later in these PDR patients. So you cannot do away with anti-VEGF and go only with PRP. So if you see this is the area under the curve. This line represents the patients with where they underwent PRP and anti-VEGF treatment if there is a sentinel macular edema. So there was stabilization of vision. We are talking about from baseline vision, the vision is not lost much. Minus 0.3 is not much loss. But if you see the group which was treated only with anti-VEGF, there was 4.5 letters in the whole group. Improvement in visual acuity with center involved, without center involved macular edema. So definitely now with anti-VEGF, we are not talking about prevention of severe visual loss. That is 5 meters, 5 by 200 is the criteria for ETDRS study to say that the treatment is successful. But here we are talking about improvement, 5 letters improvement of vision with the anti-VEGF treatment. And if you split the groups, if you see, the benefit is more in patients with baseline DME. Who patients had baseline DME, they had this also, PRP also showed improvement. This is because in baseline DME, in PRP, they have added anti-VEGF also. So the gain is 7.9 letters. So gain is more if the patient has central involved macular edema with PDR. Similarly, if you see, the gain is not different if there is no central involved macular edema at presentation with PDR. So comparable, if you have macular edema at presentation with PDR, anti-VEGFs show benefit in improving the visual acuity. Very good gain is there. If there is no macular edema at presentation, PRP and VEGF have not much improvement. Only 2 letters gain is seen. So if you analyze this data, another more than 10 letter score improvement of more than 10 letters. More than 10 letters means more than 15 letters in ETDRS means 2 lines of Snellen's visual acuity. More than 10 is approximately 1.5 line of Snellen's visual acuity. If you see, it is more in the ranibizumab group. So there is gain of more than 10 letters improvement. Less than 10 letters worsening. If you see in ranibizumab group, there is less worsening of visual acuity. More than 15 letters means 2 lines Snellen's improved. If you see ranibizumab group has increased. So we are not talking about only improvement. There is a dramatic improvement of 2 lines of visual acuity in this group. Then the peripheral visual field outcomes. Definitely, if you can see PRP group, the peripheral vision outcomes, there is a big loss. Whereas in anti-VEGF group, the visual acuity, we are definitely know that with PRP there is a peripheral vision loss, field visual loss, but it is not seen with anti-VEGF. And also central field sub-thickness changes at 2 years. See central field of macular edema. If you see PRP group, the central sub-thickness is more towards the end of the study. It is increased in fact at the end of 2 years. But in ranibizumab, the central subfield thickness is less than at the presentation mean at the end of 2 years. So central subfield thickness is better with anti-VEGF group. So complications of PDR, if you see, surprisingly, these are all comparable, like not statistically significant. But one important thing, the rate of vitrectomy is more in PRP group when compared to anti-VEGF group. So in PRP group, for some reason, recurrent vitreous hemorrhages or increase of traction, for whatever reason it is, the vitrectomy indications are more when compared to the anti-VEGF group. So anti-VEGF decreases the indications of vitrectomy in PDR. And this is never talked about in laser group. The improvement of stage of retinopathy. Eyes improving 2 or more steps of means. For example, if you are treating a patient with PDR, the chance of him becoming a moderate NPDR is 47%. You see, so there is an improvement of 2 stages. Severe NPDR will become mild NPDR, or PDR can become moderate NPDR. So there is an improvement. I mean, staging is decreased because of the anti-VEGF treatment. This was never. This can never happen with the pan-retinal photocoagulation. Pan-retinal photocoagulation, PDR is PDR. But here, if you with the anti-VEGF, if you keep injecting anti-VEGF, PDR can become my moderate NPDR, a severe NPDR can become a mild NPDR in 47% of cases. And my good friend has highlighted the point of endophthalmitis. You see, the incidence of endophthalmitis in these 300 patients is statistically not significant, and no statistically significant increase in inflammation or retinal tears or incidence of cataract surgery or elevation of IOP. So ocular side effects, everybody will talk about endophthalmitis, but in real scenario, with the number of anti-VEGFs given, the amount of endophthalmitis is very negligible. And everybody will talk about the systemic adverse effect like stroke, cardiac events. If you see that non-fatal MI, non-fatal stroke or vascular events, there is no statistically significant difference between ranibizumab and PRP group in this study. So no statistically significant ocular side effects or as a systemic side effects. So conclusion of this study protocol S is treatment with ranibizumab met primary non-inferiority outcome of visual acuity being no worse than PRP. So anti-VEGF treatment primarily to PDR is not inferior to PRP, and more importantly, mean change in visual acuity of baseline 2 years ranibizumab is no worse than PRP. Superior mean visual acuity outcomes, superior mean visual field outcomes, decreased incidence of vitrectomies, decreased development of central wall macular edema. PRP are rarely given for failure of utility in ranibizumab group. So there are many advantages of treating PDR with these two things. Advantages of PRP. So let us talk about the advantages of PRP. Typically able to be completed in 1 or 2 sittings, often long-standing effect. However, studies suggested that 45% given additional pan-retinal photocoagulation has to be done. Many may cost less than the ranibizumab injection. That is very true, and no risk of endophthalmitis and systemic side effects. I have already shown that there is no difference. So definitely it is a cost effective. Definitely the treatment is finished in less number of visits than compared to anti-VEGFs, and needs less number of follow-ups when compared to anti-VEGFs. So now PRP and anti-VEGF are not mutually exclusionary. So me and Lakshmi sir are very good friends. We are not exclusionary to each other. We are complementary to each other. So both we are all close friends and we are complementary to each other. So PRP is still the recommended treatment of choice as of now for PDR without center-involved macular edema. With center-involved macular edema and PDR, PRP plus anti-VEGF. Similarly, PDR with partial vitreous hemorrhage, where you give anti-VEGF and it increases the chance of finishing with PRP. And PDR with anti-segment neovascularization, anti-VEGF along with that PRP. And only anti-VEGF is reserved for a small subset of patients, highly compliant patients, who can understand and afford the treatment and who insist on not undergoing PRP. This is very important point. My dear colleague also has highlighted, if a patient is on primary anti-VEGF treatment and he misses follow-up for some reason for a couple of months or 6 months or 1 year, for some reason or a couple of years, we might see him blind with bilateral neovascular glaucoma. So recurrent anti-VEGF production, VEGF production will be so severe that they develop anti-segment neovascular. So compliance is very important if you are treating with a primary anti-VEGF. Thank you.
Thank you, sir. Lakshmi sir, you want to give a rebuttal to?
Dr. Chandramana has already told.
Already rebuttal is also covered in the conclusion.
Yeah.
So both of them did the same, sir. Actually, when I contacted Chandramana sir about a topic in diabetic for the debate, he said it's this is the topic he suggested. But again, when coming to the discussion, both of them are complementary to each other. They are not debating. Sudhakar sir is better.
Sir, we are here to educate the postgraduate.
I'm just kidding.
Not to give a picture of entertainment.
I can't fight with my good friend, sir.
I'm just kidding, sir. I
can't fight with him. I am one of the strongest advocates of pan-retinal photocoagulation. And I would like to listen from Ajit Babu, sir.
Yes, sir.
Yeah. Ajit Babu, sir, is an authority in diabetic retinopathy as far as I know. And we are lucky to have him.
No one can be authority in diabetic retinopathy. It really gives challenges. I have listened to both the speakers with interest, and I have seen that they covered only PDR with early PDR and high risk PDR. This is limited to this. If you see the different stages of proliferative diabetic retinopathy, you should not forget the advanced diabetic retinopathy, which has tractional retinal detachment and a combined retinal detachment and fibrovascular proliferation. This is a different stage of proliferative diabetic retinopathy, which requires surgical intervention, which both of them have not mentioned, but I want to complete that. That is one stage. The second part of the debate, which is very, very valid, which Chandramohan has highlighted, is proliferative diabetic retinopathy with diabetic macular edema. This is a very common clinical situation where even Lakshmaya told, but it is that almost 1/3 of the patients do have some form of diabetic macular edema along with proliferative diabetic retinopathy. So if anyone commits for panretinal photocoagulation, usually we have seen several cases where it has worsened the diabetic macular edema in the initial stage post panretinal photocoagulation. So it's always advantageous to combine the anti-VEGF agents for two injections or three to stabilize the diabetic macular edema first, along with the systemic stabilization before considering panretinal photocoagulation. The third aspect which Chandramohan nicely highlighted is the proliferative diabetic retinopathy with neovascularization of iris. Definitely, again, there is an advanced and severe ischemia that is happening in the retina. So first you stabilize the neovascular process with anti-VEGF injection, then address on a long-term basis with panretinal photocoagulation. That would be an idealistic situation to manage clinically. The fourth thing which is happening is, depending upon the stage of improvement of diabetic retinopathy, Chandramohan, I do agree with several injections of anti-VEGF. There can be stabilization of the diabetic retinopathy, provided they control their systemic status. If that is not done, and if they are not following regularly with the anti-VEGF, it may be a counterproductive action. Yeah, now we will come to the high-risk proliferative diabetic retinopathy, where both agents, means both anti-VEGF as well as panretinal photocoagulation, can be effectively given. In this case, you should be very, very judicious, and you should ensure that regular follow-up of the patient will be available to you. And second, they can be affordable for repeated injections. Otherwise, it can also be dangerous, because if these patients, by virtue of their inability or for the distance with which they are traveling or some other reason, if they fail to follow up, then it can worsen the proliferative diabetic retinopathy, especially with anti-VEGF injections. There can be a enhanced fibrosis, which can worsen the tractional retinal detachment. One need to be aware of that, and you should tell the patient and make them understand that they should be available for a regular follow-up. This is very, very essential. The other clinical presentation that can happen is very early PDR. Early PDRs without any fibrosis, again, good candidates for both the treatment modalities, where panretinal photocoagulation can be very effective for very long-term stabilization, whereas anti-VEGFs are advantageous if they're given 5 or 6 injections. The stabilization of early proliferative diabetic retinopathy can be reversed to a non-proliferative diabetic retinopathy. However, there are certain advantages and disadvantages that can happen with both the treatments. The anti-VEGFs, again, whatever we say, endophthalmitis is very, very rare, but it is a very severe complication. Even if one patient, I would not take it very easily in a clinical scenario. In panretinal photocoagulation, definitely there are certain disadvantages of loss of field as well as night blindness. Actually, night blindness means it is mainly the dark adaptation problem. Many of the patients after PRP will tell you that if you are going into a dark area, like in movie theater or something, it takes them a lot of time to adjust to the inside circumstances. And other aspect of pan-retinal photocoagulation, in the immediate period, at least for 3 to 6 months, there will be an impairment of near vision, especially when you are not covering the horizontal areas with a lot of this thing. However, the field loss, if one is aware of the central part of the posterior pole of the retina and do a good peripheral laser and save as much as posterior pole, you can still play with a good saving of the visual fields. Because if you see the comparison in protocol S, it is not very significant, but that is according to the standard protocol. But one need to titrate it, the laser effectively, so that the posterior pole we can save more and save the field as well. So if it all depends on a given clinical situation, you should apply all these aspects in choosing the patient correctly and applying each treatment effectively. Otherwise, both can be a disadvantageous positions.
Thank you, sir. Thank you so much. I think in the interest of time, shall we go to the next debate, sir?
Sure, yeah.
Yeah. I think we have Dr. Ramakrishnan Tadanki, sir, who is there live with us. So we'll start the next debate with him. This is iris hooks versus rings for small pupil.
Just a second.
Dr. Srinivas is also there, joined.
Yes, sir. The expert has joined.
Yeah.
That's why I told you. By age wise.
No. You are the most senior, boss.
Thank you.
Ramakrishnan sir, you can just start
sharing. I am just looking at this thing. Like mine is a Mac. I think there's something I'm not able to. Just give me a second.
Sure.
Tom, did you give access to sir? Can he share his screen?
Yes, sir. Yes, sir.
Video.
Everyone can see.
Chandramohan sir, Lakshmi sir can just unshare, sir. Yeah. Lakshmi sir can just unshare.
It's a blockbuster movie.
No, but the thing is,
the spotlight.
Can you just play the other video? Meanwhile, I'll just check my computer, get back to you.
Okay, then we'll play the video of
Sunil sir, not Sunil sir. Yeah.
Sure. Yeah, just give me a moment. Yeah. Is it visible, sir?
Just now you missed it. Yeah. Again, you are.
I'll do it again.
Yes.
Sir, is it visible?
Yeah. Yes, visible. Yes. Yeah.
I would like to begin by wishing everybody a very, very Merry Christmas and a Happy New Year. And at the outset, let me also thank APOS SOS for giving me this opportunity to talk on something that doesn't need any debate, frankly. Hooks versus ring, come on. It's a no-brainer. Of course, iris hooks are better than rings. It is time-tested, it's cheap, and if you're a real cheapskate, you can re-sterilize, it's freely available. We'll talk about the other advantages later. Whereas with rings, it's relatively new, it's expensive, cannot re-sterilize, it's not freely available, and advantages, well, zilch. There are no contraindications for iris hooks. It can be used in any pupil, whether it's rigid, whether it's fibrotic, large, small, segmental. Whereas with rings, it's very difficult to use in comorbid conditions, especially if you have a very difficult shallow AC. cannot be used in fibrotic pupils, cannot be used in rigid pupils. And in some pupils, you actually need the use of medieval instruments for stretching before actually using those rings. And some people talk about the 4 ports that you need for iris hooks. Come on, don't give me that gyan. You can make those 4.5 mm ports, no big deal. There are no special forceps required here. There is no injector required here. There is no learning curve, and it's very easy to insert, very easy to remove. Whereas with the rings, totally the contrary. You need a special forceps or an injector. You definitely have a learning curve. Maybe aesthetic in some users' eyes. So what the hell? It does take some skill, but hey ho, some people like doing things the hard way. And the iris hooks can achieve any shape or any size. You don't have to put only 4. You can put many more and achieve whatever shape you want. And sometimes you need to put more and get a different sort of shape. And you need segmental dilation in some cases. Whereas with the ring, you are stuck with a fixed size and shape. And you see the videos. I put 5 hooks on the video on the left just to show that you can use any number. And because of the extra dilation, I can go right to the periphery, very carefully watching that very loose posterior capsule. This is about the video on the left. And the video on the right shows how I'm using that extra dilation to do the scalloping in the periphery under visualization. And the sphincter damage is overemphasized. You can just gently, not overtly expand the pupil with the iris hooks. Just make your 5.5. It's not required to make more than that. And gently remove it. You're going to get the same round pupil as in any other case. Whereas, yes, you do not get much sphincter damage with the rings because it only dilates it to 5 mm. And look at this case with the iris hooks. It's a round pupil at the end of the surgery. And sometimes you need to use expansion devices after you have started the surgery. That is either you have not assessed the pupil well or the pupil shuts down mid-surgery. And you need to use expansion devices after you have done certain steps of the surgery. And it is much, much easier to use iris hooks in this situation, as you can selectively use one at a time. Whereas with the rings, it becomes very difficult, especially, as I said, if you have other comorbid conditions where you have to engage multiple flanges in maybe a shallow AC or whatever the situation. It's very much more difficult to use the rings than the iris hooks. Think about it, and it will make sense. Now, the other uses, of course, you can't even talk about the rings in these cases. When you have zonular dehiscence or zonular weakness, as in this generalized weakness in the left and localized weakness on the right, you can use these iris hooks as capsular support, engaging the rexus edge and giving vertical support. It can substitute capsular hooks. And you can see in both these cases, after putting the CTR and then putting the iris hooks as capsular support, both vertical and horizontal support, the case almost becomes normal. You can't even think of using rings in such situations. And this is another similar case wherein there is a superior dehiscence. And look what I have done. I have, after doing the rexus and inserting my CTR, I put iris hooks superiorly to the capsular edge and pull the bag up superiorly. Now this serves 2 purposes. One is it gives vertical stability, and next it blocks the vitreous from prolapsing into the anterior chamber by pulling the lens across. And small incision cataract surgery, you cannot use rings, because if you use a ring with a small pupil in a small incision cataract surgery, when you deliver the nucleus, the ring also will deliver. Whereas that's not a problem with the hooks. And there is a way to put the 12 o'clock hook, which I can deal with in a later discussion or a forum. And these are more of those examples where I've used iris hooks for small incision cataract surgery. These are very complicated cases of a small people with an extremely advanced cataract, post-KP, and a phacolytic glaucoma. And sometimes in the floppy iris, you know it's a floppy iris, you know it's going to shut down on you, but initially the pupil is large. So you cannot put a ring on a large pupil, whereas you can put iris hooks prophylactically across that pupil and prevent it from shutting down on you. Moreover, with the irrigation, with a ring, you will still get iris flutter, whereas with the iris hooks, the flutter is largely reduced. And another advantage of the iris hook is you can do hydroimplantation with iris hooks in place, whereas you cannot do that with the ring because you are going to have flutter of both the ring and the iris when you do under hydroimplantation. And this is a special case. This is a coloboma uvea. Obviously, there is no iris below, so you cannot put a ring. So I have segmentally dilated the case. And you know these cases, these colomomatous eyes can be extremely difficult to handle, and you need all the help that you can get. That's what I've done with the iris hooks. You can see even the triton blue has gone into the vitreous. These are very complicated cases to handle. And similarly, look at this adherent leukoma. You cannot put iris ring here. So I've just opened up some of the synechae and segmentally dilated that iris, broken some synechae. Go ahead, do the rhexis. This is a very complicated case. This is a one-eyed patient. And here I'm using the microrhexis forceps and Utrata to form the rhexis. And then in my normal speed, do the phacoemulsification and put in the hydrophobic lens, and all goes well, thanks to those iris hooks. So in conclusion, need I say more? It's a no-brainer. Hooks certainly score over fancy rings. And if you still have a doubt, well, I can only think of one thing. There's some people, I mean, you can wake up somebody who is unconscious, but you just cannot wake up somebody who's pretending to sleep. Thank you. Merry Christmas. Have a wonderful evening.
That's a good one, sir. Good one.
RK sir, are you ready?
Yeah, I think I'm ready. Let me see.
You have to do it strong, sir. Sunil sir made a good presentation.
Yeah, I think it's opening now.
Yes, sir. Yeah. Play, yeah.
So thank you very much. Now I'll be talking about small pupil phaco with the aid of pupil expanders. So it's always a confusion, always a dilemma whether to place a pupil expander or not. So whenever you have a very small pupil, there is absolutely no confusion. But if the pupil is moderately dilated, we are slightly confused. We try to avoid an extra procedure. So we try to save time. So in some cases, what will happen is the pupil will become small in the middle of the surgery. Then the whole surgery becomes a mess. So instead of that, it's always better to place a pupil expander. So after a few years of experience, we do a big number of cases. We start becoming really comfortable with phaco in small pupil with the aid of a pupil expander. But some cases pose a challenge, especially a soft cataract. So in this kind of scenario, it's always better to place a pupil expander. So at the end of small pupil surgery without a pupil expander, this is how we feel. It's like uphill task. It's a very difficult surgery, but at the end of the surgery, you feel really happy and elated. But is it really necessary? Why to struggle when you have pupil expanding devices at hand? So I'll just show two videos here. So which one is better and safer? On the left, you have a case in which I have put a pupil expander. In the right, I am doing a small pupil phaco with the aid of the pupil expander. Which one you feel is better and safer? So in the best interest of the patient, is always better to place a pupil expander. It's really good for the patient. So we have a few indications. We have the absolute indications and the relative indications. So the absolute indications are small people with very soft cataract, and small people with very hard cataract, with intumescent cataract, floppy iris, and the pseudo exfoliation. So the relative indications are all other cataracts where the pupil is inadequately dilated. So I have tried many. We have many choices. I've tried many, but my personal favorite is the Gupta ring, and I don't have any financial interest in this one. So this, as with any other expansion device or any other new procedure, we have a bit of a learning curve in this one. You need about 20 to 25 patients for you to become really comfortable. But once you become comfortable, then your whole surgery becomes very, very easy. I remember in my first patient, I think I've taken around 20 minutes to 25 minutes in that case, but now I take less than a minute to place a pupil expander. So it's always better to use Hylocoat or Viscoat, especially if you have a shallow anterior chamber. So to elaborate, so the use of pupil expander soft cataract, the best technique is soft cataract, as we all know, is wide rexis and prolapsing the nucleus out of the bag, doing the lens salute technique. But in case you have a small pupil, you don't put a pupil expander. So one tends to make a smaller rexis. If you have a really soft cataract, the cracking nucleus is really difficult. The nucleus cheese wires, nucleus doesn't come out. You keep trying, and after some time you start panicking. So after you start panicking, you somehow want to finish off the surgery. So you start doing aggressive hydrodissection, which can cause a PC blowout and nucleus drop. So it's always better in soft cataracts to place a pupil expander to do a clean surgery. So removing a soft cataract in a small rexis is difficult even for accomplished surgeons. In hard cataracts also, it's always better to place a pupil expander as we do surgery with very high parameters. When we are operating with very high parameters, what will happen is that we might accidentally injure the iris. If the iris gets injured, it keeps coming to the phaco handpiece whenever we activate the aspiration with the foot pedal. So which precludes efficient phaco emulsification. In pseudo exfoliation also, we need to place a pupil expander because just in case we have undiagnosed zonular dialysis, placing a CTR in the absence of pupil expander becomes really difficult. And intumescent cataracts also, because of the ever-present danger of the Argentine flag sign, and in occasional patients, the rexis keeps running out to the periphery. So to retrieve the rexis one needs to have a widely dilated pupil. And in floppy iris syndrome also, is always better to place a pupil expander. Floppy iris is something which we don't diagnose in the OPD. So this is something which we see on the table. So it's when you preoperatively examine the patient in OPD, if the pupil is not really dilated, it's always a good idea to inquire about tamsulosin usage, which is an alpha blocker, which is used for BPH. The inquiry about tamsulosin is not going to change your strategy in any way, because IFS is known to cause even years after discontinuation of tamsulosin. But if you know that the patient is on tamsulosin, will be mentally prepared for a difficult surgery. So what will happen in floppy iris? In floppy iris, the iris keeps billowing and the iris keeps prolapsing out of the ports we make. So with each attempt to push the iris inside, the pupil becomes even more smaller, and then the surgery becomes very, very difficult. So if you keep the pupil expander, it keeps the iris at bay. So your surgery becomes like any other normal case. And it's always better to place a pupil expander at the slightest doubt. So timing, when to place. So after assessment of the OP, if you feel that the pupil is not adequately dilated, it's always better to place a pupil expander. But sometimes in the middle of the surgery, the pupil starts becoming smaller. You have an intraoperative myosis. One can also always place a pupil expander instead of struggling in the middle of the surgery. So if you place a pupil expander, the surgery is like a cakewalk. It's like any other normal surgery. So my suggestion is to place a pupil expander even at the slightest doubt, instead of struggling in the middle of the surgery, in the best interest of the patient. So how to position the pupil expander? So we have these elastic pupils and the fibrotic pupils. In elastic pupils, there's absolutely no need to stretch. You can just straight away put the pupil expander. But if you have a fibrotic pupil, it's always better to do a stretch pupiloplasty before placing the pupil expander. So the technique of placing the pupil expander, I have my views here. So others might differ with me. But I always place the trailing scroll first. So what I do is, when I inject the pupil expander into the eye, I inject straight away into the anterior chamber. One should desist from the temptation of engaging the scrolls while injecting itself. So I just inject into the anterior chamber. I just leave one scroll out of the incision. Then I place place the trailing scroll first. And after that, once you place the trailing scroll, the 3 o'clock, 6 o'clock, and the 9 o'clock scrolls come within your reach. If by accident you place the leading scroll first, what will happen is it will push the trailing scroll into the subincisional area. So once it goes into the subincisional area, it becomes really difficult for us to fish it out. And at times we might end up inducing iridodialysis as well. 1 second. The video is not changing. Just give a second for me. Hello?
Yes, sir.
Your slide is not moving, sir.
The slide is not moving. Just a second.
I think you went into the pen mode, sir. You had your...
What?
We had your marker mode. Yeah, now you can.
So now I'm going to show 3 videos where I'm placing the pupil expander. This is a case with the moderated dilated pupil. One might wonder why I'm putting a pupil expander in this one. In this case, the
video is not playing, sir. Please see.
Sir? No, I'm yet to play this. So the cataract is very soft, so it didn't want to take any chances. As I was telling, I just inject into the antechamber, leave one scroll there, and then with the Sinskey, I just place it at the pupil expander with the second instrument in the left hand. I position at the pupillary margin. So the second instrument, I call it as a modified Sinskey, the tip of which is a regular Sinskey, the tip of which I've broken and got it grounded in a foundry. So all the scrolls are placed, and then one can position the pupil expander also according to our comfort. So the next one is a small pupil, the much more smaller pupil. Even in this case, the cataract is small, so I'm just injecting the pupil expander into the anterior chamber, and all these scrolls are positioned. So the most important point that I want to make here is that the trailing scroll has to be positioned first instead of the leading scroll. So likewise, the last scroll is also positioned. So you can always adjust the position of the scrolls with the Y-shaped nucleus rotator. You can bring it into your comfort zone, and then you can position the scroll with the Sinskey hook. So the last scroll is positioned. So one can also do a one-handed technique. So you just inject into the eye. So with the, you don't have to use any other instrument in your left hand. So with the Sinskey, just put it into the anterior chamber, go up to the pupillary margin, and just pronate your wrist so that the scroll goes into the, goes onto the pupillary margin. So just pull it, bring it to the pupillary border, engage there, and then pronate. Simple. So intraoperative MICE is also one more situation where we may have to place a pupil expander, but there are a few points we have to remember because one can potentially cause a rhexis break. So if you have already made rhexis and then the pupil start constricting, then one should always think of placing a pupil expander because it makes your surgery easier. So the technique is to deepen the anterior chamber with the viscoelastic. One should create a space between the capsule and the iris by injecting the OVD, which will lift and tent up the iris, creates a space there. So you can always place the pupil expander and do the surgery as usual. So how to disengage? Just deepen the anterior chamber, disengage the scrolls with the Sinskey hook, and then just slightly lift it up from the iris and then pull out with the capsule forceps. So the pupil expander can be slightly dialed also. You just lift it up and then pull it out with the capsule forceps. So regarding the iris hooks, I'm not a great fan of iris hooks for the simple reason that we need to make multiple ports, 1 for the main port, 2 for the side ports, and 4 for the iris hooks. Whereas in pupil expanders, just one main port is sufficient and a normal regular 2 side ports. So apart from that, if your tunnel is slightly anterior, you may not get the kind of adequate dilatation you would like to have. So I use iris hooks only if I have a sectoral iris shaving to keep the iris in position. So with the iris hooks doesn't look nice, looks shabby, and looks like this. I don't like it. In the best interest of the patient, whenever you're in a doubt, never hesitate to place a pupil expander. It saves few missed heartbeats. Thank you for watching.
Great.
Thank you, sir. Maybe you can
unshare, sir, please.
Yeah.
Yeah, 1 second.
Yeah, I don't think we have Sunil sir to have the rebuttal. So, yeah. Sir, I think now the subject expert, Srinivas sir, can take over and give his final verdict.
Thank you very much for the opportunity. No, nothing much to add or moderate after two stalwarts spoken about the iris management. Actually, in my view, with a moderate, pupil, small, with a nucleus is not that much hard, implantants will do the job. How many are doing swing cartilage? Because in my practice, almost when there is moderate dilated pupil, I am doing sphincterotomies, and usually I do it temporal incision, and with that I make a large nick at 12 o'clock so that lid will cover that, and not much photophobia. Coming to iris hooks may be beneficial in a very small people or atrophic people, but more cosmesis with rings. And the rings are relatively expensive, almost 5-6 times than the iris hooks. That's the only problem or contraindication in my view. Nowadays we are getting Gupta ring. What Tadanki used? Is it Gupta ring or?
Gupta ring, yeah.
One more, I used a few B-hex rings. They're definitely very good, but pretty expensive, not available also. And in my routine practice, first preference was iris hooks because they are cheaper, and for many years we are using it. And in only we attempt this iris hooks are pupil expanded devices when the pupil is very small. Otherwise, the experience of this Sunil and Tadanki is quite different. They have mastered these techniques. Thank you very much.
So just one point I would like to add here.
Yes,
like I was just watching the video of Dr. Sunil. So one thing he was saying is that if you put iris hooks in floppy iris, so iris doesn't cause any problem. But if you place a pupil expander, it still billows. I do agree with that. The iris still billows, but it's like it's held in position. I keep saying there's one example I'd like to say. It's like a barking dog which you put on leash. It keeps barking, but still it's not going to bite. You just put a pupil expander, then whatever billowing is there is not going to really hamper your surgery.
That's true. Yeah.
Sir, I think one practical point would be the size also, sir. Like you have a limitation with the rings to the size you can increase the pupillary margin, whereas in hooks you can pull it to the periphery also.
Yeah, carry on, Anish.
Yeah, the size is okay. Like, you can comfortably manage in Fago, but I do agree about one point. In SICS with a very large nucleus, I think the pupil expander doesn't work because, as he was telling, Sunil was saying, it will deliver the pupil ring also out of the eye. So there's no point in these pupil expansion rings. I think are exclusive for Faco only. It's not for SICS.
I think
the one disadvantage about iris hooks is if you have iris hooks, what happens is the pupillary margin is pulled towards the limbus. See, when in iris hooks, but the pupillary expander rings dilates the pupil in the plane of the iris. So there is advantage of it. That means the iris is not obstructing your phaco probe into the main incision. Suppose if you are doing iris hooks and you are trying to enlarge it to the full maximum extent, what happens between the two iris hooks? The pupil margin comes as a straight line. It obstructs your entry of the phaco probe. So that is the reason why the pupil expander fares better in all situations. But the two exceptions are, as Sunil rightly pointed out, the colobomas. When you don't have a iris tissue in some one place or one-fifth or one-fourth of the iris, then there is no role for your pupil expanding. These iris hooks fares better. The other point is when you have a small eyes, microcorneas, then the pupil expanding has no role and the iris hooks have a better place. And when you have a lot of posterior synechia, extensive posterior synechia, the comorbid condition, the complicated cataract posterior cyclitis, then the iris expander rings will not have pupil expanders will not have a much role. The iris hooks will play a little better than that. But during the surgery, if you have a small pupil midway the surgery, then I think pupil expanders will face better compared to the iris hooks. Because when you are trying to implant or inject iris hooks during the midway surgery, what happens? The iris hooks will have a place in between. There is a small place, and this catches the capsulorhexis margin. But in case of pupil expander rings, you can always catch the iris edge or pupillary edge, so that the capsulorhexis margin is not coming into the pupillary expander rings. So those are the main differences how you can plan according to your surgery. Regarding the BH things, the BH things so thin. Sometimes, if you are having the higher parameters, sometimes the people like the BH things comes into your port. So they're so thin. There's not much of a heavy inside. That's one thing. The scroll is always better in the Gupta Singh or Malagrini or whatever it is. The scroll is always better. It holds the pupil margin and it dilates well pupil. The sizing is not a big problem in my view, because most of them we are all making around 5.2, 5.3 millimeters of excess in all our phacometers. We're not going up to 6 millimeters anyway. So these pupils will always make at least the 6 millimeters or 5.5, 6 millimeters. So that's not going to be a problem in any way. And in case of very small ACs also, as rightly Dr. Sunil or Dr. Ramakrishna mentioned, when you are using a viscoelastic, you use AccuCoat so that you protect the endothelium. So the chondroitin sulfate protects the endothelium better. Try to use that. And don't fill that. The practical tip is don't ever fill the antechamber fully with the viscoelastic. Leave some space so that the pupil expanding will go there. The iris hooks, another disadvantage of the iris hooks is sometimes some people may damage the capsule while implanting the rixis. Sorry, this is the capsular ring, the capsular hook. The capsular hooks, the tip of the capsular hook is not very rounded. Unlike a capsular hook, the iris hooks are not rounded. The tip of the iris hooks are not rounded. Sometimes if you are implanting and catching the iris, sometimes the tip of the iris hook, the tip of the hook will scrap against the capsule and it may damage the capsule and you may have some amount of capsular opening in there. Then we have to convert that opening to a good capsular. So these are the small little points I would like to add here.
Thank you, sir. Thank you so much. I think, that finishes today's session. And I must congratulate Gopal Krishna sir for designing this wonderful debate and involving all the specialties and speakers in the concerned specialties. Thank you so much, sir. If anybody has anything to add.
It's better to give postgraduates some doubts. If they have, you should answer them. They can send a message to you people and then you can do that. That will make them also feel involved in the whole
correct, sir. Yes, sir. Yes, sir.
We'll take this in the next session, sir. Thank you.
Definitely.
Sure,
it's mainly for us to improve along with them.
Yes, sir.
Yeah. Gautam, do we have any questions in the chat box in the website?
I'm checking, sir, in a minute.
Okay. So I think Gopal Raju sir, if his sir is there, we can conclude it.
Yeah.
What about one thing about sterilization? Dr. Sunil told that hooks can be sterilized. How can with ETO or?
Yes, sir.
Even the ring also can be, sir. Gupta's ring also can be re-sterilized with ETO if you want to. The Gupta's ring, I cannot say about other reasons. Gupta's ring is tough. You will sell at least 1 or 2 cases if you want to really do ETO. Even I did with Malagrini ring also, sir.
Okay.
Even I did. I used Malagrini ring for at least 2 times for all my other cases.
They're pretty costly at that
Very
time.
costly, sir. Very costly. Yeah. Madhu, are we done here now?
Yes, sir. Yes. J.R. Reddy, sir, any closing comments, sir? J.R. Reddy.
No, extremely done well. There are no more comments.
Yeah.
Right. Thank you, sir. Thank you, Ajit Babu, sir, for sparing the time Saturday evening for us. Thank you so much.
No, I learned a lot here. Because other specialties are there, no? It's always better to listen to other specialties. That's how I improve my ophthalmology.
Yes.
Sir, there are few questions, sir. I have posted in the chat box.
You have posted in the chat box?
Yeah. You should always encourage this.
Sure.
So that a lot of involvement will be there from the postgraduates and they feel involved.
Did you post it now?
Yeah, I think he has posted.
We didn't see anything.
We are not able to see any questions, Gautam. Otherwise, you can send it to me directly on WhatsApp also. Yeah. Does peritomy help?
There are few are there, not does peritomy help in non-resolving PUK?
I think we'll restrict to the topics of the particular this thing, sir. These are all not related to the
I know. Yes,
debate, but
it is
anyway, we'll
mainly
try to answer them.
infective keratitis.
Yes, sir. Yes. Yeah.
EOAC.
This
No,
is all
Madhu, you just mentioned in this thing that it related to topics, the postgraduates can ask their questions.
Yes, sir. Yes, sir.
In each this thing, in the chat box, they can place their questions.
Sure, sir. Sure. Okay. So then we'll conclude this session, sir, because all of them are not have gone through the 5 questions. All of them are mostly related to microbial.
They are mainly infective keratitis.
Yes.
It's Madhu's area.
Thank you, sir. Then we'll call this a day. Thank you all once again for participating and
it's nice initiative, Madhu. I think these webinars shall go on. And maybe discuss with everyone that what are the pertinent topics for the postgraduates as well as practicing ophthalmologists. It will be very, very useful because we can share our experiences and then directly they can apply in the clinic.
Yes, sir. Yes. Thank you, sir.
Okay. Good night. Good night, everyone.
Sir. Thank you all. Thank you.
Gopal Krishna did a good job.
Thank you, sir. Thank
Excellent
you.
job. Not good.
Excellent
job.
Good, then next word is excellent.
You are reserving the excellence for others.
So next month, I think the program is led by KVV Sachinarayana sir.
Okay.
It is a glaucoma update. That will be in January 3rd week. By the suggestions given by all of you, I think we'll put it on a Tuesday or Friday. And timing also would be 7 to 9, sir. That would be convenient.
Okay.
Tuesdays fair because we are East Zone. We are always doing on Tuesdays. Because whole of the zone is involved in that.
Sir.
Tuesdays, please spare.
Okay,
Friday,
sir. Okay.
Probably
We will take it on
Friday. Friday is okay.
Friday.
Okay, sir. Friday. Yeah. Thank you, sir. Thank you all for your time. Thank you very much.
Okay. Good night.
Good night, sir. Thank you, sir. We are signing off, sir.
Good night, Madhu.
Leaving the
Good night.
meeting.
Good night.